Good afternoon. Welcome to Burning Issues. This is a contemporary current affairs show on IETV that we do every week. Of course, currently we are doing it on a Tuesday afternoon, but by the next 2 weeks or so, we'll be moving to live show at 8 p.m. on a Thursday night. For the time being, however, we'll continue with the Tuesday afternoon show and repeat it on the Thursday night. But when we do get into the live shows on Thursday night, we will not have the Tuesday afternoon live program. Burning issues, as I said before, is current issues, contemporary issues, burning issues which impact upon citizens in Trinidad and Tobago. And today, April the 5th, what are the burning issues? Well, in the main, we could start by saying, yesterday we opened back up the economy. Everything else was open. Save most of the mandates had gone, save and except, for instance, that we still need to wear the mask. And of course, we now have a license to go and party and do whatever we want to do. But of course, the onus in doing all of that would be upon us to exercise the self-discipline if we are to keep the COVID-19 virus at bay. But of course, Trinidad and Tobago has, in relaxing all or most of the mandates and so forth, have followed several other countries. And what are we seeing in several other countries? Well, we've seen a rise in cases in many countries. So for instance, in the United Kingdom, in England, they had some 5 million cases last week. So is that something to be concerned about? My colleague on the show, Dr. Bahal, will tell me, well, we shouldn't be worried about the amount of cases. What we have to be worried about is simply the amount of people who are actually ending up in hospital. And yes, we know that the numbers are going down slowly, but they are going down as to the numbers in our medical institutions. But that brings us to treatment in the medical institutions. And today we want to spend some time on treatment in the medical institutions for COVID-19 and other sorts of issues, because we've seen in the newspaper over the weekend, for instance, that the regional health authorities is racking up a serious bill in terms of negligence claims being made against the regional health authorities. And we're going to discuss that a little bit later in the show too. But we have to deal with the health system per se, and we're going to talk about that in the show. Before I get to that, however, what are some of the other major issues? Well, for all intents and purposes, we have to start talking about things that are affecting the ordinary person. And the ordinary person is going to be affected by the price of food. National flour mills have already indicated that if at the rate at which they're going, they have not made profits from last year based on the increases in the price of wheat, and they expect the price of wheat to go further up. And not only wheat, but all other grains, corn, rice, everything else will go up. And who's going to have to pay for it? We are, the citizenry. We've been told, for instance, today that the price of eggs are going up. And of course, once the price of eggs go up and flour go up, of course, bakery items will also go up. So we will all have to deal with that. And of course, our salaries seem to be staying the same. Of course, yes, the government will tell us, well, we've started negotiations with the public sector unions. But starting negotiations doesn't mean to say that we're getting anywhere, and they will get anywhere soon. We know for a fact that in judgment given by the Industrial Court, TNTEC workers was given 0.000% increases over 3 years, for 3 years gone, because they say that the commission could not afford to pay. Not that the workers didn't deserve an increase, but the commission could not afford to pay. At the state of the economy, can the government afford to pay increases in salaries? Well, that's a whole different issue. We're going to have to deal with that on a different day. For today, however, what are some of the other burning issues? Well, sadly enough, I should say, 2 children died by drowning over the last week. And we are officially into the Easter vacation period. So it is now up to parents to make sure that they take care of their children, supervise them well, particularly so around pools, whatever type of pool you have, supervise them well, because we don't want to lose the children. And then too, crime is still on the upsurge, as well as motor vehicle accidents. We are losing people on the roads too. So these are critical issues that we're going to have to deal with. But we're going to talk health today and the healthcare system and what is happening and what are the shortcomings therein after a break. We take a break now and we come back with burning issues. Welcome to Burning Issues on IETV. Burning Issues is a contemporary show that is going to be dealing with current affairs. While we talk about the pandemic, while we talk about the issues of health, crime, be it public utilities, be it taxation, be it the economy, how we diversify. It is now for us to talk about these issues, and this we will be talking with in the show for the next few weeks on IETV with Dr. Mandrika Bahal and I, Vishnu Raghunath. We talk burning issues.
This Easter, win a Tobago Weekend Getaway on IETV's Easter promotion. Simply like the IETV Facebook page, correctly answer a trivia question with the hashtag IETV Tobago Weekend Getaway, and share the Tobago Weekend Getaway post. Promotion runs from March 31st to April 20th, 2022. A live draw will take place on IETV on April 22nd. This promotion is sponsored by Surfside Hotel and Tobago United Auto Rentals and approved by the National Lottery Control Board.
Welcome back to Burning Issues. As I said in the introduction, we're talking about the health system today, the healthcare system. And today, well, we have had an interesting article in the newspaper today as pertaining to the report which the COVID investigation team would have done on the medical team would have done on how the hospitals were managing COVID-19 and their cases. We have on the line, online with us Dr. David Bratt, who is the author of that article that is on today's newspapers. And we want to invite Dr. Bratt to join us to tell us what are really his concerns. Now, bear in mind several things. One, when the Prime Minister had appointed that committee to investigate the healthcare system, he had initially told them he's giving them a week. And then from a week we went to a month. Then we got a report, and the report is there telling us certain things, but of course it starts off with an apology. So Dr. Bratt, welcome to Burning Issues, and tell us your concerns about the report that we have on from that COVID-19 medical investigation.
Thank you for inviting me. I'm very, very glad to be here. You already mentioned one of the two concerns that I had, which is the amount of time that was given to the team. Really and truly, it's a bit of an insult to give a team of 5 professionals 1 week to look into the management of over 2 years of management in a number of hospitals, not one, number of hospitals of varying degrees of intensity of care, thousands of cases, over 3,500 deaths at the time. So to give people 1 week either shows lack of knowledge of what was needed, or something else. The team then asked and requested more time. I don't know how much more time they requested, but they were given an extra 3 weeks. And very soon, I think they realized that this was not enough. So they then decided that they would do a rapid assessment. Now, again, the idea that a nationally appointed team of professionals to look into something as important as the management of sick people during the greatest epidemic that Trinidad and Tobago has ever had. The idea that they would think, or they would expect, that all they could do was a quickie, a rapid assessment of this situation is really is bewildering that they agreed to do it. That's the first thing. And obviously, you can't with a rapid assessment. All you're going to get is rapid, quick answers. You're not going to get anything in depth. And so said, so done. Now, there were a number of interesting things that they came up with that I won't go into detail because they don't concern me. What really concerned me as I continued to read was the fact that they were given access to 25 patient notes. Now, if you were doing an audit of patient care of, like I said, thousands of cases over a 2-year period at various levels of management with more than 3,500 deaths, you simply need to look at a large number of cases. You need to do a random sample of these cases. And that is going to take a great deal of work because some of these patients would have been hospitalized for 2, 3, 4 weeks. So, and you have to sit down and go through every day and see what was done and what wasn't done and come to a conclusion about the management of the cases. So right away you can see this is you talking a 6-month thing to do. They were given a month and they accepted to be given a month. And then as initially I am informed, they asked for a random sample of 300 cases out of, I assume, the 3,500 deaths that people who died, but I'm not clear exactly where they had decided to take these cases from. The RHAs refused on the grounds that there wasn't enough time. So they then, I'm told, requested 90 cases. The RHAs again refused to cooperate, saying there wasn't enough time, and citing, I believe, patient confidentiality. And then the RHA then decided to choose 25 cases and give it to them. And it's on the basis of studying these 25 cases that they have come up with most of their findings and their observations. And I think this is quite inappropriate. And I think basically that, as I say in the article, those findings are useless for anyone who wants to know what was really going on in the hospitals during the time of COVID, during the outbreak of COVID.
And that in itself tells us the challenge that we have in accepting not merely the recommendations, but rather the outcomes of this report, because for all intents and purposes, many people have their, well, everybody who went through the COVID challenge and illness have their own stories to tell, and some of their stories are markedly different to what other people would tell you. And we all know of people who have had their various stories published in the newspaper one way or the other, and what we saw coming out of the report would be one where it leaves a lot of more questions to be answered rather than anything else. Now, I agree with you that the 1 month period would have been too short for them to do. But what is really concerning to me is the failure or the refusal of the RHAs to share the information, notwithstanding that this was a government-appointed investigative team. And for all intents and purposes, they were telling the government, well, look, we really don't care about you. How do you respond to something like that?
Well, I think this is, I agree entirely with you. This is one of the most salient features of what came out, that the RHAs, which dependent on the government, basically were telling the government-appointed investigators, sorry, we're not cooperating with you all for whatever reasons. And for me, that is unacceptable. And I think we need to repeatedly stress that point, that the RHAs refuse to cooperate with this team of doctors. And that is absolutely unacceptable. And what needs to be done next, I don't know. I would assume that, I don't know. I really don't know what the next step is. As far as I'm concerned, this report merely scratches the surface, and there is need for a further investigation of some sort, whether it be a national commission of inquiry, which we all know we have all the time and nothing ever happens, or whether there's going to be just individual doctors talking to each other, or medical societies coming together as doctors and discussing what went on in during those 2 years. I should point out to you that up to now, there's been very little, if any, discussion on the part of any medical society in Trinidad and Tobago, whether it's the Trinidad and Tobago Medical Association, or whether it's the Pediatric Society of Trinidad and Tobago, or whether it's the Surgical Association or Obstetrical Association of Trinidad and Tobago. There has been literally no discussion among doctors about what was going on, what is going on, and what do we do in the future if the same thing happens. And that's really one of the key things that we need to be able to plan for the future, because we all know there's going to be another pandemic sometime in the next 10, 15 years, maybe even before.
Dr. Brett, you probably know me, Mandrika Bahal. I was a medical student of yours. I remember you showing me a jersey once in classroom. This jersey have a few holes. It was there before the oil boom, during the oil boom, and after the oil boom. I never forgot that, up to today. Anyway.
Thank you. I can't remember that, but I'm glad that you remember.
Yeah, but I remember you telling us you showed the jersey in the pediatric ward with a number of holes. So it was there before the oil boom, during the oil boom, and after the oil boom. Anyway, one of the other things the commission had to do was to determine the cause of death. I thought that the commission, the Simongal committee, should have clarified what they meant by the cause of death in the death certificate. But from my reading of the summary and a few bits and pieces here and there, that was never addressed. Can you enlighten us on that if that was addressed at all? Because a lot of patients say they were dying from heart attack and they marked it on COVID as the cause of death, and not in the other section 2, where there may be other causes but not directly contributing to the death. But once you have COVID written in the certificate, regardless of the time, and the committee was supposed to clarify the determination of death in their evaluation.
Yes. Well, of course, the amount of time that they were given to clarify something like the cause of death is almost impossible to do. That includes the composition of the committee, which didn't include a pathologist. So that of itself, that is an extremely difficult thing to do. People all over the world have had difficult to do because of the lack of time and lack of composition, but also difficult because all over the world, people have had difficulty with this thing. What are people dying of? If you have COVID and you die and you get a heart attack and you die, what is the cause of death? Is it the heart attack? Is it the COVID? Is it the COVID trigger the heart attack? Did the heart attack affect the COVID? These are very difficult things for the ordinary doctor who is there when the person dies, and then they have to sign the death certificate. And many of these people we know in the parallel health system who are junior doctors with very little experience. And I can tell you that I myself, with over 40 years experience in Trinidad and Tobago and more in the States and in Venezuela, you still have difficulty in deciding exactly what the cause of death is, many times with simple cases. Far less for these junior doctors, who I assume were the ones, I'm not sure, were the ones signing the death certificates, and for them to decide what was the cause of death. And I'm unclear what the position of the ministry was. Was the ministry saying, the Ministry of Health saying, once you die and you have had a positive COVID test, or you had COVID-like symptoms, then that was put down as the cause of death? That is a very unclear. It's unclear all over the world. People on the CDC, for example, just did a review of their mortality in the States. And in the case of children, the figure in adults is they found about they reduced the cause of death from COVID by about 70 to 75,000 cases, which they decided at that time was not due to COVID, it was due to the other factors. They did the same thing with children. They reduced the number of children who died of COVID in the United States from about 1,800, which is an amazing figure when you realize that over 1 million people have died and less than 2,000 children under the age of 18 have died in the United States. It's now down to 1,350 or something of that sort. So there is need for constant revision of what people are doing. And again, this committee, there's no way that this committee could have come to any sort of conclusion to clear this up in 1 month's time. And I think for that reason, they probably never tried. Because I agree with you, it's not clear in the report.
If I may come back to that issue, Dr. Bratt, where you said that there's been little discussion about this report amongst the medical fraternity. How do we get this going? I mean, because for all intents and purposes, I know I have spoken individually to certain doctors who would tell me and raise concerns not only about the report, but rather about the whole process that went in from the time we started with the pandemic all the way down to the report and even post-report. But while they would talk amongst themselves or talk on an individual basis, why is there this reluctance to treat with this head-on?
Well, this has been an ongoing theme for the last 2 years. The Private Medical Association has really been absent from the discussion table. From the very beginning, I made various attempts to get in touch with some of the leaders of the the Trinidad and Tobago Medical Association, and really was unable to establish any sort of communication with them. And I have those emails. I have those emails for anybody who's interested. And there was really the doctors working in the public sector cannot speak up. They cannot give interviews. They cannot talk publicly, which is another problem of its own. So you couldn't expect them really to come out publicly and make statements. The only organization that I know of that was repeatedly making statements is the Trade Union Association. Their president, Mr. Stewart, has repeatedly come out in public. So in a way, the doctors in the Ministry of Health took control of this pandemic, and they were the ones who were attending at the conferences. They were the ones who were speaking, giving interviews. From time to time, they would bring a public health official, a pediatrician, a cardiologist, or somebody to come and sit down with them and say something. But there's been no discussion by the general body of medical practitioners in Trinidad and Tobago about the management of the outbreak, with rare exceptions. There have been an epidemiologist, an internist from San Fernando, myself, and some others who from time to time comment. But these are isolated incidents. And I agree with you, there's been no desire on the part of organized medicine in Trinidad and Tobago to publicly discuss the COVID pandemic, the major medical event in our lifetime, and probably for the last 100 years or so. So which is a bit surprising. And I think the medical association, the medical profession has not come out very well, looking very well. The doctors in the hospitals did their best. I know that, it's like the nurses and so on. And that probably is enough, but we really don't know why this has happened. There seems to be a fear. There seems to be a fear that people are going to be disciplined or punished of some sort if you come out and the fact that I, as a medical professional, let's say pediatrics, I have no idea how many children in Trinidad and Tobago came down with COVID. And I'm a senior pediatrician. I taught everybody. I don't know, I can't find out. I keep asking. It turns out that the pediatricians, apparently there are pediatricians in the parallel health system who take care of all of the children with COVID, but they refuse to talk to the public pediatricians at the Children's Hospital or at Port of Spain or at San Fernando. So they don't know, we don't know, we just don't know. And the idea that I, as a medical professional, can't talk to another medical professional and say, listen now, what is happening now? What are you all doing? What drugs are you all doing? How do these children present? What are the laboratory findings? I can't. I never found out. I've been trying. Several of us have been trying, because we needed this information in our private practices to say, okay, the main way that children present with COVID is this and that. So we're looking for that in our when the children present. We don't know. We simply don't have that information. It really is poor.
System among doctors. You know, every week we may have a grand round on a unique topic. And over the last 2 years, there has not been any clinical discussion on the ICU care or the ward care of patients to see what type of patients we have in terms of hemoglobin or white cell count or ESR. Nothing whatsoever in the primary care system. So they themselves, I'm not too sure if they're scared to collect notes and do analysis of 30 or 40 cases in the ICU department.
All I know about COVID in children in Trinidad and Tobago and in general is what appears in the press.
In the press, correct.
The press. So comorbidities, obesity, diabetes, and so on and so forth. But the exact percentages,
no,
no idea. Now, one of the interesting things, by the way, that came out of the report was, we know that obesity and old age and diabetes are probably the 3 major factors associated with deaths. Well, it turns out that in the ICUs, many of the patients could not be weighed. If you can't weigh a patient, you don't know how much they weigh. If you don't know how much they weigh, you can't decide if they're obese or not. You can look at the patient and say, clinically, they look obese. But it couldn't be done. And I think the expression used that many of the young doctors, they didn't have any orderlies. They didn't have enough orderlies, so they couldn't weigh the patients. Or it may be that the patients were so sick they couldn't stand up. So there's no way to weigh them when they're in the bed. So how do you know that they're obese? I don't know. I don't know how that was arrived at. But that's just an interesting little aside, showing one of the failures, one of the lack of equipment to be able to assess and decide whether someone is obese, overweight, or what.
I was actually going to just touch on that, Dr. Bratt, because it's important for us as an economy and as a people of Trinidad and Tobago to agitate for a deeper conversation in terms of reviewing exactly what occurred in a major time in this country of Trinidad and Tobago. We've essentially been shut down and shut in for 18 plus months with margin or just recent reopenings. I think it is important and incumbent on the citizens of Trinidad and Tobago to use whatever forum that we have access to, whatever platform we have access to agitate for those kinds of conversations to come out in the public and make it clear that it's not about pointing fingers. It's really about picking up clearly what are the root causes of some of the gaps that were glaring and that emerged as an open need in the system and remedying it in an efficient way. So I am very surprised that there isn't that push from the medical associations, from some of those bodies to say, hey, let's come together and see collectively what were the challenges and how can we ensure to the benefits of the people of Trinidad and Tobago that this does not happen again,
Sure, and many of these things can be done in a professional level, standard manner, it doesn't have, we don't have to go public with this thing. We just
Yeah.
amongst ourselves as professionals decide, okay, we went wrong here. This was well done. This is what we have to, and move forward.
Yeah.
That has not been done, and it still is not being done.
Okay. In your view, how can we get that kind of conversation happening other than, you know, how can we get everyone on the same table? I know you said earlier that you tried to reach out to the medical board to no avail, but what are some of the other steps that as a senior medical practitioner in Trinidad and Tobago who is seeing the need for this kind of conversation to be able to get those parties on the table?
I am, perhaps, you know, we've gone through this entire pandemic, and there's a lot of anxiety around, there's a lot of depression around, and I'm afraid I feel the depression.
Yeah.
Because I've been writing about this in The Guardian for at least 2 years. I've written over 100 articles about what's going on, and with very little uptake from anybody, very little interest from anybody. Programs like this, I think, are useful to educate the public. If we can do it objectively and let people see that we're not pointing fingers, we're not blaming anybody. We just want to know as professionals what happened. But I am afraid, I agree entirely, you know, with Dr. Bahol that there doesn't seem to be much interest in the medical profession about finding out what is going around. And I, again, apart from talking out publicly like this,
Mm-hmm.
And maybe in other forum, then I don't see what else can be done.
Okay.
As you indicated, that there's always the possibility that another such pandemic may hit us some years down the road. And my biggest fear is because of the way we have tried to keep this thing as opaque as possible, lack of transparency, we are not really putting ourselves in a place where should something else of a similar nature happen 5 years or 10 years down the road, that we'll be anywhere better off than we are today. And yes, that I think is a real concern for persons like myself who are not medical professionals. And we really would like to ask and hope that the medical professionals would now take it upon themselves to kind of start the conversation.
I think the Simongal report did allude to the fact that more research needs to be done in terms of stakeholder customer satisfaction. More research needs to be done looking at the data from the ICU department and exploit a little more to be able to. So I feel that we need more doctors or public health specialists or clinicians go out there and ask the Ministry of Health to get ethical approval and do proper research in that database that we have created because of the pandemic, unfortunately. So that pandemic period, all that data that we have on patients, doctors or whoever it is must ask the Ministry of Health to access it to be able, in a proper way, through ethical approval, to be able to do proper research so we can know the state of health, not only to determine gaps in the system, but to know the way these pandemic patients present at different levels of care, whether they have a low platelet count or a high white cell or this or that or respiratory changes. But we need that data to be documented in our local context. And the only people who I feel could do that, provided we get the files from the North Central Regional Health Authority, is through researchers.
But I have a question as it relates to that.
Excuse me.
And that question...
I think this is where UE comes in. I think this is where UE comes in.
Oh.
Because this is the sort of thing that UE, the medical faculty, this is what they should be doing now. It's possible that they're doing it and they haven't told anybody.
Yeah,
but I agree totally with you, sir.
Mm-hmm.
Yeah, so we need the research, but my question here is simply this. You made a statement there that I am worried as to whether that statement is factual. And you said that a database has been created. I am not sure whether they actually created a database in the parallel healthcare system.
Yeah, well, there's two. One in the files and raw data form, and then there's one in the Ministry of Health, which have this data. That's how they get that epidemiological profile on a daily basis in terms of how many people were in ICU, how many people in step-down care, different things. But it's not really what doctors need on a day-to-day basis to manage patients. So the clinical database, which is in the raw data form, is in the file room which Dr. Simongal and his team couldn't access. They only gave him 25 patients. What kind of patients are those? I'm not sure. But that random sampling that they were hoping to achieve to be able to know a little more of that 3,500 deaths, they couldn't get it. So we need a proper research to be done to be able to access that raw database, and if you want to put it that way. But there is data. It's not nowhere hidden. It's there somewhere in a form that I have to access, but through some medium, whether through ethical approval, and they would have to give it to me. But that provision is there. Whether they give it or not, or they really want to hide, that's a separate matter.
No, you see, and you raised that, and I must say that one of my concerns, for instance, because when people, even citizens, go to the public health system and ask for their medical records, sometimes they actually pay and still don't get it.
Yeah, well...
And I mean, and that's in the regular healthcare system. When you talk about the parallel healthcare system, my question is, are we really going to find all of these things?
Quite frankly, I don't think it's a problem to find, because of the nature of these cases, they will be somewhere stored. It's whether they are willing to take it off and give it to you. The one in the traditional healthcare system, they may lose it somewhere or go into some ward and they couldn't locate it. But in the parallel healthcare system, I am sure they have extra security to ensure those files are well kept. I'm just speculating here.
and with that, Dr. Bratt, let me thank you for joining us and for raising the issues. These are critical issues. In closing, do you have anything else that you would like to add before we close with you today?
Well, two things really. You mentioned the business of personal responsibility and the opening up of society apart from the rapid antigen test to come into Trinidad and Tobago and the masking. I too am concerned, and I too am concerned about what is going to happen opening up a week before Easter. What is going to, last year we saw what happened with the Easter parade in Tobago, and then school opening up for a couple of weeks, a week later after Easter. And I'm afraid, I think we should, unless our population is more immune to the Omicron variant than it is, than we know how it is. I fear the same thing is going to happen as is happening in the States and in the United Kingdom. This explosion of cases. And I just want, my final point is, please don't say it's the schools that is causing this. All right, the schools are going to open up at around the same time as we're going to have this outbreak, and people are far too quick to want to blame the children, and they want to blame the schools. Remember that the school is the last thing you close and the first thing you open, which is, by the way, exactly the opposite of what is happening in Trinidad. We closed the schools, we left the bars open, we opened the bars, we opened the KFC, the cigarette factory, and so on. We still haven't opened the schools. So please keep that in the back of your mind, that it's not the schools. There's never been an outbreak of COVID because schools opened and children went back into schools.
Thank you very much, Dr. Bratt, for joining us on the show Burning Issues today. And we take a note of that. Bear in mind that school is reopening on the day after Easter Monday. So for all intents and purposes, everything that is going to happen over the Easter weekend will not be, ready for that day after Easter Monday when schools reopen. Thank you again, Dr. Brad, for joining us. And
Thank you for inviting me.
this is Burning Issues. We're going to take a break now and come back with the conversation. We break. Welcome to Burning Issues on IETV. Burning Issues is a contemporary show that is going to be dealing with current affairs. While we talk about the pandemic, while we talk about the issues of health, crime, be it public utilities, be it taxation, be it the economy, how we diversify. It is now for us to talk about these issues, and this we will be talking with in the show for the next few weeks on IETV with Dr. Mandrika Bahal and I, Vishnu Raghunath. We talk burning issues.
Are you interested in becoming a news reporter? IETV Newsroom is offering internships. Send your resume to news@itvtt.com.
Welcome back to Burning Issues. So we're talking medicine today. We're talking about the whole issue about what has happened in that report and the investigating committee for COVID and so on. And that's one aspect of our concerns about medicine today. The other concern that we have with medicine today is simply the issue of the amount of cases we are now hearing about in terms of negligence or malpractice amongst the doctors and the medical fraternity in the public healthcare system. It's not only in the public healthcare system, because we've seen in the media, for instance, there are reports where citizens are suing doctors in private practice also for medical malpractice or negligence. But what we know for a fact is simply that the regional health authorities are racking up a significant bill in terms of paying legal fees to their own lawyers, and we're not yet talking about the settlements as relates to medical negligence. Dr. Bahal, tell me, what are your real concerns with regard to this?
Well, medical malpractice or medical negligence stems from some underlying thing in the healthcare system, which tend in some way to not adhere to quality healthcare. Now, so that whatever going on, it stems from that underlying problem. And my concern here is that why are we spending such huge amounts of money in legal fees, 37 million? It means, therefore, the total bill in cost in terms of settling malpractice could be in the amount of hundreds of millions. Like England, if they spend 1.5 billion in malpractice, 1/3 of that is usually in legal fees. So if we do that same kind of extrapolate, 37 million, it means that the cost of settling the dispute, as I said, might be over 100 million per year. Now, Trinidad and Tobago just 1.4 million people. But I want to take you back a little more in this terms of this malpractice. What exactly are we paying out money for? And I just want to point out it very quickly. Malpractice or medical negligence, malpractice is when you have a legal connotation, but medical negligence is when when professionals through a negligent act or omission deviates from standards in their profession, thereby causing injury to the patient. And I mean, you can have negligence in terms of diagnosing the patient or treating the patient, and in the actual process of the care, whether they're doing it in a timely manner or not, and leading to demise of the patient or some disability. So that's medical negligence in a board. We came from the Wikipedia encyclopedia. Now, this money that was paid out, 37 million for medical negligence. I wanted to know.
Just let's be clear. This is not that's not the bill for negligence.
No, that's the legal
fees.
Right.
That's what the lawyers
get. So the legal fee. So the whole cost might be over 100 million.
Right.
Now, I just want to recap something here, which might be helpful to understand that this is not going to the doctors or the medical institution. To get a medical report from a doctor, where he has to look through the whole file, this came from the RHA website. A medical report, it costs the patient, and the doctor gets $37.50. Or if it's a junior doctor, $22.50. So the doctor, in the whole process of providing a medical report for a patient who wants it for whatever reason, embassy, going abroad, wherever it is, it's a small little fee. So the healthcare provider, that system, doesn't give much weight in terms of remuneration to the healthcare provider. But lawyers, $37 million. The customer, the patient, much more. Why is that so? And I mean, there are a number of areas that, when you talk about malpractice, all the mission and vision statement of the ministry, they talk about being patient-centered and providing for excellence and all these different things. So, if they have that mission, like say the Ministry of Health, let me just take the Southwest Regional Health Authority, right? Their mission statement, just to give you an idea of what they should be doing. The Southwest Regional Health Authority is in the business of promoting wellness and providing compassionate, cost-effective, and customer-focused healthcare to the people of the region. Now, that goes exactly in sync with what is meant by quality healthcare, as defined by the Institute of Medicine. Safe, effective, patient-centered, timely, efficient, and equitable. But when we don't adhere to these things, we end up with some kind of contravention of these, and the patient now feel unhappy. And if it makes the patient in any way feel that they could seek redress from it, they seek to go to the court. And that's where the medical malpractice comes in, because of these negligent cases, whether through any of these things that supposed to be done for quality healthcare. Now, many patients cannot afford. So what you see in the $87 million in legal costs, or $120 million to settle these things, is maybe the tip of the iceberg in terms of what really goes on in the healthcare system. But even though the mission statement is to do all these things, who is really ensuring that? The Minister of Health, the Chief Executive Officer, or the quality department of each of the RHAs? I don't know. In fact, all of them are supposed to be doing that. Everybody's supposed to be involved in that. But we are not doing that. And hence the reason why we have such kind of practice. I'll give you another case. I mean, look at what happened recently in the press. I feel so hurt about it. This child needs to get a cochlear transplant for a couple of $100,000. A young child. Now, I'm not going in detail about it, but a young child did not get any help from our healthcare system. She had to beg and rake £62,000 or US dollars to be able to arrange this money to get a cochlear transplant. 2 years of age. But I could provide you a man who is with a heart attack, died. We see all kind of complications. I could provide you with free angiogram and open heart surgery costing $200,000 or close to that. But a child, and we may have a life expectancy, a remaining part of it, probably about 10 more years. But the child who has 60 more years to live or 70 more years to live, you refuse to grant. So what is the equity involved? So this child here, I have a feeling baby Vedika gets surgery because she had a rake and scrape. What do you think about that? That any kind of equity?
Well, you see, that takes us away from the where we want to focus on. Because you see, you're talking about a different issue altogether here. Equity in healthcare treatment. But our concern here is the amount of negligence, supposedly.
Well,
no, you raised, before I allow you, you raised an issue that doctors get something like $37.50 to do a medical report. Now, that was simply because the client or the patient pays, I think, $75 or so.
No, they pay $37.50.
Oh, that's what they pay. So they pay $37.50 to the hospital to get the report.
To give the doctor to provide the report.
But the point about it is that question, is a report not part and parcel of the work of the doctor?
No, reports in general are part and parcel of the doctor if it's for to improve their care. But if you wish to get a special report to go to a lawyer or to wherever, if I have to write a medical report on a patient to give to another doctor, that's free of charge. But if the patient requests a special report on his file to send to the embassy, to wherever he chooses, I am obligated to provide a report at a small fee. But that small fee of $37.50 is there for the last 4 or 5 decades. Has not changed. I was just showing you the comparison between when how much doctors get for their reports as opposed to the legal fees that we end up paying somebody completely outside the health system.
All right, so that's one aspect of it. But coming back to the whole issue of negligence and how do we treat with negligence? You talked about the quality control people within the Ministry of Health, within the RHAs and so on. To what extent do those quality control mechanisms work for us as citizens in Trinidad and Tobago?
But to make it very simple, it does not work. I'll tell you why. If you have a process, now there are 6 areas in which you can look at, and that's what Dr. Simoga's report spoke about as well. 6 areas, but let me just take a look at the efficiency one, right? How things are done in a particular way to be able to make sure a patient receive, let's say, augmentin as an antibiotic to treat a particular infection. That whole series of things. If you are not monitoring what takes place when the patient arrives, so when the patient receives the medication, how would you know if it's efficient? If there's nobody in that institute could tell me all patients who reach in the hospital diagnosed with a pneumonia get their antibiotic augmentin within 1 hour of arrival, or within 1 hour of seen by a doctor, or based on some benchmark which may be 3 hours from arrival if it's a non-emergency, and you tell me they all receive it 36 hours after, that's not being efficient. That's not being efficient. Or in other words, if they are not being monitored, and these quality departments do not monitor these things, they may look at the odd case and try to, like what is happening in the pipeline issue with the divers. They have a lot of meeting to discuss what went on and the process and go with flow chart, but not in immediate to see, well, look, let me take a sample of patients within a week, and I say, look, this is a gap here, let me plug the gap. So our system then, because there's no monitoring, how can you tell me I am efficient?
So let's go back to that earlier conversation we had with Dr. Brad.
Right.
When he said the RHAs only give the commission, the investigating committee, 25 cases, which the RHA selected. So in other words, there was no random sampling of who's been selected. In the particular case that you're referring to here, quality control, are they really?
No, that is an interesting point. The holding back of information cannot allow to determine a proper evaluation. Once you hold back data, how can you make a proper evaluation? Right there where your sample is biased. There's no way you could have a proper evaluation. You might get to say, well, look, out of these 25 patients, they all receive the pregnancy loan, but even so, when did they receive? It's much more to, you have to look at a much more in-depth analysis to know when they came in, how long after they were screened, when it was prescribed the medication, when they received it, how many times they were turned every 2 hours based on international benchmarks. So right away, if that is not done, so that single point you mentioned about giving 25 files, I consider that holding back major data for the evaluation. So the whole evaluation, like I said, becomes to zero more or less. In fact, it shows up more weaknesses of the healthcare system from the provider point of view, that they are not, or policy making point of view, that they are not being open for quality control.
Now, okay, so in a way, we've reached this point where we wanted to go into another segment on the show today to talk about transparency, but we don't have the time to do that. But I want to bring that whole issue of transparency as quickly and in a nutshell as you could put it. Why do we have that problem with transparency, or the lack of transparency in?
Well, I should be asking you that question. You are a man and chairman of the Transparency Institute at that time. But transparency in healthcare, I think in clinical medicine, once you have proper ethical approval, there should be none whatsoever in terms of trying to hide information because about healthcare. I could understand, but in healthcare, there's a very much close link with politics. And that healthcare politics dichotomy, which should be supposed to be far away as possible, seems to be getting itself into our healthcare system. And our doctors are being, Dr. Brad said, there's some fear going on. I mean, I could understand. I remember when I did a study on dengue, and it headlined the Guardian mark, dengue outbreak exposed. You know, Mr. the Inwood wrote back and said he don't know who is Dr. Bahal doing a study and all these things. But there should be no fear. It's about clinical medicine to make our lives better. Of course, there may be issues where somebody might realize that this particular person is more likely to be responsible for this problem, but that's not a problem. We should not use it to kind of crucify people, but more to help the system. We want to know about COVID. So that transparency, I think, should not be an issue at all in the release of any document concerning the health of patients and to make the overall good of the community for public health even better. And once patients or their relatives allow us to use the information, we should have access to it fully to make sure we have proper health care.
Okay, so let me ask you a final question that as a political scientist, and I stick to my own territory, as a political scientist, you made the point that there's a concern as to the politics of the medical fraternity. There have been allegations in the past that, for instance, the Medical Association is controlled by persons who belong to one particular entity or supporters of one political party and not the other one.
Well, I wasn't going on there. I was saying politics in the sense that if I give all this information, I may lose my job. That kind of dynamics there. If I give this, I wonder if I could be in the favor of the politician now or the minister. I might be doing something wrong. So that element of control and politicking is there. But in terms of the overall sphere of what you're talking about, I wasn't trying to go
party
down
politics.
Party politics.
Right. Yes.
Politics and jump for your own survival in the organization.
All right. So there's that concern, and that is something that we will really have to pick up at a later date. In fact, we ask the Medical Association some of these questions at some point in time as to whether or not they would be willing to discuss it. We still have to ask the question about whether there's that degree of transparency that is available. Ladies and gentlemen, you have been viewing Burning Issues. We've been trying to keep up with all the things that are going on in the medical fraternity right now. There's a lot more that we could talk about. People are concerned as to what type of medical healthcare treatment we get at the hospitals, and more importantly, to what extent is there that significant discourse and conversation even amongst medical practitioners, not only in the public health sector, but those within the private health sector, whether that conversation is happening at this point in time to all in all to hopefully make our healthcare systems better. This has been Burning Issues. We'll have to continue the conversation next week. Again, for the time being, however, we'll say good evening.